Hey class, how you doing? Hope y'all are doing well through as we start this new week. This week we're going to be talking about social epidemiology, which is fun. We're going to get into a little bit of lecture today. It's going to be a shorter lecture because I really want this week to focus on this little bit of case study examples that I'm providing in the slides that you'll be able to see. And then the second half of the week, the quote unquote Thursday section, is some asynchronous self-direction time where I want you to watch the lecture by Dr. Maples on social epidemiology. And the link is in the Moodle page and on the syllabus. And then we have an article response. So the first assignment is due by the end of the weekend on Sunday. So make sure that you're working on that, using that self-direction time to do both of those. But for now, we will get into our lecture today on social epidemiology. And I mentioned the article response. So this is just another reminder. You can take a look on the Moodle page about what that actually entails, and I'll show you exactly where that's at. So if you go to the Moodle page, scroll all the way down under the assignments, it is the first one listed. So you can see the actual structure of that assignment. Please let me know of any questions you have. And then under the assignment due date on the course schedule, under week 4, along with your feedback prompts, your discussion prompts, there's an article response due on Sunday. So you can use that link to submit it. If you have any issues with that link, you can also email me a Word document version of your assignment. Okay, let's get into social epidemiology. So maybe you've heard of epidemiology before, and we'll talk about what the difference is between classical epidemiology and social epidemiology. But really, I want you to think about what comes to mind when you think about that word epidemiology, because there are distinguishing features between conventional epidemiology and social epidemiology. Your conventional epidemiology focuses on biological and genetic factors, while social epidemiology focuses on societal conditions. And that's going to make more sense as we get into this. So, social epidemiology, you see the definition up there, is the study of how social structures, interactions, and inequalities influence the distribution and determinants of health outcomes in populations. So, social epidemiology emphasizes contextual factors such as socioeconomic conditions, cultural norms, public policies, other social determinants of health, like we talked about last week, all these things that go into shaping health. So the purpose of social epidemiology, what it does, it broadens the lens of traditional epidemiology. So instead of focusing solely on pathogens and genetics, individual risk factors like epidemiology does, it rather examines systemic and structural influences on health outcomes, like the things we mentioned last week, like income inequality, neighborhood environments, social networks, access to resources, income. And the goal here for social epidemiology compared to traditional epidemiology is to uncover and address root causes of health disparities to achieve health equity at a population level. Again, remember we talked about upstream versus downstream approaches. Your downstream approaches are a lot in traditional epidemiology, those treating symptoms, treating diseases. But really, what social epidemiology is looking at is trying to prevent the spread of diseases by looking at upstream effects. So, looking at what are the root causes of these things, the social root causes of these issues. So again, conventional versus social epidemiology. So conventional epidemiology, for those folks who maybe are more unaware, the purpose of conventional epidemiology is to study disease patterns on biological agents, things like viruses, bacteria, and it focuses on those individual behaviors and genetic predispositions to these disease patterns. So, for example, investigating the transmission of influenza or mapping cancer-related gene mutations, focused on reducing the prevalence of certain diseases and spreading prevention of those diseases. Now, social epidemiology focuses on those social factors like poverty, education, housing, discrimination, other social determinants of health, like we talked about, and how those things shape health risks and outcomes. So it explores why certain diseases disproportionately affect marginalized groups versus other groups. And so an example here compared to the influenza or cancer-related focuses maybe of conventional epidemiology. Social epidemiology might analyze how food deserts contribute to higher rates of diabetes in low-income neighborhoods and focusing on what are the social and root causes of that. And some key areas, some key things to be aware of, key terms for when we talk through social epidemiology. Obviously, the social determinants of health, right? Those social and economic conditions that shape health outcomes. We talked all about that last week. Health disparities, so how differences in health outcomes across different social groups appear due to inequitable access to resources. And then health equity is another term to be aware of. So health equity refers to the pursuit of eliminating health disparities to ensure that everyone has a fair opportunities to achieve their highest level and best degree of health. So be thinking about and be having those in your mind because we've talked about each of those, but those are really fundamental to as we talk about social epidemiology. Some other key concepts to talk through. So primary, secondary, and tertiary prevention. So these terms are introduced in the Joseph, the reading from 2006, and I want to explain these concepts here just in detail. So when we talk about epidemiology, it's focused on the prevention of diseases. So again, conventional epidemiology is focused on how do we prevent the prevalence of certain diseases by mapping risk factors and genetic predispositions. Whereas social epidemiology, we're looking at the root causes, those upstream effects of disease prevention at a population level and a social level. So primary prevention are those proactive measures to prevent the onset of diseases. So like vaccination programs, anti-smoking campaigns. Secondary prevention are early detection strategies like screenings for high blood pressure, screenings for diabetes, those sorts of things. Tertiary prevention are managing chronic conditions to prevent complications. So this is where you're managing like diabetes, diabetic management programs here, where you're preventing secondary stages and advancements of these conditions. And so Barkin chapter 2 talks about this as well, and I mentioned the Joseph reading. So make sure you're referring back to Barkin chapter 2, where what he's doing there is providing an overview of social factors that contribute to health inequalities. He's talking through things like socioeconomic status, race, environmental exposures, and exploring the impact of community structures on access to healthcare and the implications for public health policy as it relates here. And then the Joseph reading, this is a case study on asthma disparities, and it's highlighting how applying more multi-level prevention strategies can further and better mitigate health inequalities. So, for example, addressing racial disparities in asthma involves community education. That's an example of primary prevention. It involves regular screenings, an example of secondary prevention, and then it also involves comprehensive care plans, tertiary prevention. So especially the Joseph reading is talking through is that, especially in social epidemiology, there's more than just individual risk factors and genetic components that go into epidemiology and preventing disease onsets. It's these three key factors here: primary, secondary, and tertiary prevention. We have to do all three. One is not the only answer. We have to do all three. We have to do the education. We have to do screenings, and we have to have culturally competent care plans as well. So each of those things go into there. Those are really key components of social epidemiology. And let's move into some theoretical insights as well, some of the other readings. So the 2018 reading here is a good cornerstone in understanding the evolution and application of social epidemiology. So where the other ones actually explain it, here they're talking about kind of the evolution of where we've been and where social epidemiology is continuing to go. And so their work emphasizes the importance of social capital and community health in shaping public health outcomes, especially in the face of contemporary challenges like we talked about, right? Increased urbanization, increased globalization, and global disparities on the health front. So that social capital, having the ability to make changes and having authority and agency in your life, and then community health as well, are really, really important factors as we look at addressing issues and challenges that are arising from urbanization and global disparities. And so let's talk about what they mentioned in the 2018 reading, the evolution of social epidemiology and that role of social capital. So what they're arguing is that this field of social epidemiology and health in general must adopt new methodologies like social network analyses to better understand how relationships, community dynamics, digital interactions influence health, right? That's going back to the social determinants of health, and how those social determinants look different than they did 50 years ago or even 10 years ago because there's this digital community and social network landscape. And so the authors are saying we need to make sure that we're including those components as well in our social network analyses. And that social epidemiology is increasingly relevant for addressing complex global health issues, not just community-focused national or transnational issues. Things like urbanization, migration, and global health inequalities really require this focus. So that's the argument of the authors. And then they talk about the role of social capital as well. So social capital, as a reminder, refers to the resources available to individuals and communities through their networks of relationships. So the greater, the more relationships that you have that you can use and leverage to make changes in your life, to advance in your life, to get to the point where you need to get to have resources. Maybe it's health-related resources, educational-related resources, whatever it might be. That's social capital. It's really, really important here and a key foundation in sociology. And so what the authors are saying here is that high levels of social cohesion, things like what we refer to with social cohesions are things like trust or mutual support and cooperation in your network and in your communities. And so high levels of social cohesion in a community are linked to better health outcomes, especially during crises like pandemics, like natural disasters. We saw that so prevalent in the COVID-19 pandemic. So that social cohesion and social capital are things that are often ignored by traditional epidemiology as beyond just traditional risk factors or genetic predispositions. Rather, what the authors are saying here is that in social epidemiology, we have to take into account those are levels of social capital. How do we get access to resources? Not just our resources available out in the world out there, but how do we actually get to the point where we can access them? And where is our social cohesion in our community? Do we have a tight-knit community? Do we have a community that there are proper support structures and trust and cooperation? So, for example, communities with strong social networks and high social capital often share health information more effectively, often offer emotional and material support during crises, like food distribution during a pandemic, because there's more resources available. And these communities also oftentimes experience lower rates of stress-related illnesses due to those communal support and resilience. Conversely, though, fragmented or even disconnected communities oftentimes may face greater challenges such as misinformation spread or limited resource sharing in issues like pandemics or other sort of natural disasters. And other discussion points I want to just mention here, the global perspectives on health and the importance of the social network analysis. So the global perspectives on health here. So thinking about high-income countries versus low-income countries. So high-income countries often focus on chronic disease prevention, so like obesity, heart disease, driven by lifestyle and aging populations. Whereas low-income countries often face problems more so related to infectious diseases, malnutrition, and poverty as primary health challenges. So more focused on those primary rather than preventative components. In social epidemiology, in these contexts, must address structural inequalities and limited healthcare infrastructure. So one of and we're going to talk more about global disparities in global health. And this is going to be a heavy emphasis here about high-income countries versus low-income countries, because it's really important to understand that difference. It's important to understand high versus low-income communities within nations. But when we look at this global perspective, especially through the lens of social epidemiology, there's some really unique challenges and focuses here. Then the importance of the social network analysis. So the social network analysis helps us to identify how information, resources, and behaviors spread within and between communities. So it's really useful for mapping the spread of diseases or understanding the effects of interventions such as vaccination campaigns, anti-smoking campaigns. Offers also insights into how marginalized groups can be better integrated into public health initiatives. So it allows us to identify where these network ties exist and how information can be spread. And as we're implementing new public or population health initiatives, by having a good understanding of a social network in individual communities, we can better plug in those initiatives. And that also comes from, remember what we talked about in the previous classes, of including members of a community that we're trying to implement a new initiative, especially marginalized communities, by making sure that we include them in the planning and implementation process, because that's a way of conducting a bit of a social network analysis. How do we understand better that community? So, and you can even practice this on your own, right? Think of your own social network. I know this person who knows this person who knows this person who knows this person. You can build out your entire social network, and you can see the difference between a strong or a weak or a large or a smaller social network and how you can plug into that. It's networking 101, right? You're going to probably do this in your careers if you haven't already, but think about that from a public health standpoint of when health information or health related resources need to be spread across the network, how important that becomes. So just a quick takeaway, by integrating social capital and network analyses, social epidemiology offers more actionable insights into how public health strategies can be tailored to strengthen communities, address global inequalities, and enhance resilience during health crises. That's the big idea here with these readings. So addressing health inequities. So this really comes from the Marmot and Bell 2016 reading. And really what this reading is, it's more of a call to action for making social inequality a primary focus in public health and epidemiology. And it emphasizes that health inequities are not just medical issues, but deeply rooted in social and economic structures. So they're really addressing that inequality. They're highlighting that addressing inequality is critical for reducing health gaps and improving overall population health. So it's a really good reading to summarize and be more of a call to action. So some core arguments here from the reading, you can see them up on the screen: the health disparities in socioeconomic status, economic policies and social structures, and then evidence from their review. So let's start with the first one: health disparities and socioeconomic status. So again, the argument from Marmot and Bell here is that socioeconomic status, race, and employment conditions, again, those social determinants of health, are foundational in creating health disparities, and that these disparities often manifest in shorter life expectancy, higher rates of chronic illnesses, and worse health outcomes in marginalized communities. So, additionally, economic policies and social structures. So the authors are discussing how inequitable policies such as regressive taxation or inadequate social safety nets, these things exacerbate those health gaps by that lens of the social determinants of health, especially when we're looking at the economic side of things. And policies promoting economic equity, like raising the minimum wage or expanding public education, can mitigate these disparities through just greater emphasis on not just economic advancement, but economic equity. That's a big component here. And then some evidence from the Marmot Review. So what they found in their study was that they found stark differences in life expectancy and health outcomes based just on income levels and geographic location. So for example, residents in wealthier areas often had longer life expectancies and better health compared to those in poor neighborhoods. So again, take a look at that reading as that more call to action, right? So they also connecting what the authors are talking about to current policies that may directly influence health, like minimum wage laws, access to education, universal health care issues, as we look at global disparities, right? And so the big takeaway here is through addressing social determinants of health, like that Marmot and Bell are talking about, and structural inequities, public health policies can better promote health equity, leading to better outcomes for all populations, not just those in privileged circumstances, right? But I really encourage you to look at the potential role as you all, right? Your potential role as maybe health professionals someday, as advocating for these sort of upstream policies, as we think about this from a more ground up level, right? If we go back to the earlier slide, primary prevention, secondary prevention, tertiary prevention. It can't just be one of those things. It has to be that primary prevention is so, so important. Those are really proactive measures. And those proactive measures are only more effective when we take in those social determinants of health, our community-specific focuses of how we think about these things more holistically from the ground up. So, The last thing that I have is, and I'm not going to go over in detail actually, because I'm charging you to actually go over, is a case study overview. I'm presenting two different cities here, is City A and City B. So City A is a high average income, well-funded public schools, clean environments, and accessible healthcare, whereas City B has low average income, underfunded school, high unemployment, and limited healthcare facilities. And I want you to think about, and you'll see in the notes, there's a lot more detail for you. But before you look at kind of the answers or the details in the notes, I want you to look at and think about structural factors potentially contributing to health disparities in City B, such as things like inadequate housing, food deserts, or lack of public transit. Explore how City A's investment in public health and infrastructure leads to better outcomes. So think about those things, and then I really want you to think about specific policies or interventions that could improve health outcomes in City B. So try to identify what you think could be potential interventions or policies, especially those upstream prevention and policies, right? Those primary preventative components. And then you can include that in your weekly discussion prompt as well. So we'll talk more about this, and I may be following up individually some folks and asking about your ideas here, but you can go into the notes and look at in-depth analyses that I wrote up for City A and City B, and then some key structural factors contributing to those disparities in City B. So be thinking about those things. The last thing as well is that Dr. Hotspot video. So this is another case study to watch. So this is one of the assignments that wasn't a written an article assignment, but was rather something to watch. And it's a PBS Frontline documentary and discusses Jeffrey Brenner's approach to identifying what he terms as hotspots of healthcare needs. So make sure you go into that video link and look at that. And some key takeaways from that video is the use of data to identify patterns who are high utilizers of healthcare services and focus resources on targeted community-based care, showing the efficacy of that. Again, those more community-focused, community-involved upstream preventative measures. And then the video also discusses how this approach reduces healthcare costs overall and improves patient outcomes by addressing underlying social issues. And the relevance here to social epidemiology, this really demonstrates how social epidemiological concepts can translate into actionable community healthcare models. So this is a really good applicable example to see how we apply the things we just talked about. And kind of applying the social determinants of health to preventative measures. That's what social epidemiology is. And then applying social epidemiology in a real world setting. That's what this video does. So again, it's important. I want to emphasize the importance of shifting from a more reactive to a proactive healthcare model. That's the big idea for today. And then I want you all to think about how community-based initiatives help address the root causes of frequent emergency room visits, like things like inadequate housing or lack of primary care. How do we address those issues and then relate those to a public health preventative measure? So that's all for today, but I want to also remind again, the article response is due here. So please let me know of any questions you have around the article response, social epidemiology, anything we've talked about today. Again, as always, happy to meet one-on-one, but take a look at those case studies and the details in the notes that I've written up for you. But try taking a stab at it on your own as well. So, all right, thanks everyone, and I will see you next time.